Okay, we are going to get started now, covering theory 3 and 4. We're going to start with chapter 16, and I have divided it into two parts because it's quite a bit of information. We're primarily covering laboring patients. So there's different schools of thought as to why labor starts. Uh, they say that there's lots of different things that could happen, and so we'll talk about those in just a minute. But we know that the physiologic effects of giving birth, the woman, of course, experiences the contractions. They are intermittent. Okay, there's a rest period in between contractions. Of course, as labor progresses, they become more frequent, and there's less time to rest. But this also allows the placenta to get more blood flowing back in there, get more oxygen and so forth to the fetus. The uterus itself is kind of like a big globular balloon almost, and at the top has a lot of muscular fibers that contract down, helps push the fetus down, and it also helps efface or thin the cervix so it will pull up over the baby's head. And of course, dilation is making the cervix wider. So effacement is about the thickness or the thinness of the cervix, and dilation, of course, is about it's bigger. It's getting bigger so that the baby's head and shoulders can get through. So this is just a picture of how it happens. As you see the top one there, the cervix, the lower part of the cervix is it's passive, so it's very responsive to these forces. And then as it forces the baby down, it kind of slides up over the head a little bit and the presenting part, whatever it might be. So here is just another view of a primipara or prima gravida, however you want to say it. Um, her cervix has never been opened, it's never been dilated, and so it takes a little bit longer. And as you can see, in before labor, you can see that the cervix is pretty closed there. And then compare it with the multigravida, or the multipara. Her cervix has been dilated, and so it will thin and dilate a little faster and a little easier just because it's happened before. Okay, so the fetal response is based upon several things. Of course, the placenta circulation has to be adequate for the baby to adjust to the intermittent contractions where the blood supply might be, a little bit inadequate or diminished as of what it had been. But a healthy fetus will adapt. And so there's enough in the reserve to help with that. The cardiovascular system reacts very quickly by increasing the heart rate lots of times just to compensate. And then you see here the pulmonary system, the lung fluid production in the fetus decreases and it absorbs more as late pregnancy and labor continue. And then the compression of the thoracic cage during labor and coming through the birth canal helps expel any additional lung fluid. And that's why it's not unusual after babies are born when you're listening to their lungs, they may have some crackles, but that usually goes away. And then because a C-section baby doesn't go through that process, doesn't go through that birth canal, then oftentimes they'll have a lot more secretions and you'll have to use the bulb suction a lot more. And they may have a little more secretions for longer and more moist lung sounds for a longer period of time, just because they have not had that thoracic compression. So when we're talking about labor, we're talking about the 5 P's. The passenger, of course, is the fetus. The passageway is the birth canal, obviously in the woman's pelvis. The powers are the uterine contractions and then the mother's pushing. The position of the baby is very important as well, as if it's head down and turned the right way. And then the psychological or the psyche of the patient is affected by this. So the two powers of labor are the uterine contractions and the maternal's uh, pushing efforts. During the first phase of labor, that means the onset of labor through dilation. Remember, dilation is 10 centimeters, up to 10 centimeters. The uterine contractions are the primary force of making this baby go through the pelvis, through the birth canal. After the second stage, when dilation is complete, 10 centimeters dilation, 100% effaced, then the woman usually is encouraged or may even feel the urge on her own to push and get the baby moving out of the body, out through the pelvis. Okay, let's see. Hold on a minute. Get some notes here. All right, the passage. So the passage is the birth of the fetus because of the maternal pelvis and its soft tissues. Now, the bony pelvis becomes a part of laboring process because the bones and joints don't always yield very readily because it's quite a thing there. And then the cartilage has to be able to move, and they think the hormone relaxin increases. It just all helps to hopefully make everything a little more pliable, a little more flexible, so that the baby can actually move through a little easier. Then the passenger. Okay, so that's the fetus. Okay, now when we talk about the fetus, we talk about the head. Okay, it's the size of the fetal head. There's bones in the fetal skull, as we know, and they're pliable. And sometimes babies come out from the birth canal, and they have what we call molding, where they have what we call them cone heads. Sometimes the anterior, the front of the face to the back of the head is elongated, but those go down, and it has to mold sometimes to get through the pelvis successfully. Of course, there's something called the fontanelles, the anterior and the posterior fontanelle, and we'll be talking about in that in just a minute. Of course, the presentation of the fetus, we want it to be head down. Okay, we want it to be cephalic. We prefer it not be breech because that could be the buttocks first, or even one or both feet first. And a shoulder presentation, there's no way that baby can get through the birth canal. So lots of times a breech and another unusual type of presentation will result in a C-section. Okay, so the fetal lie, or how the baby relates to the mother, is the relationship of the long axis of the spine of the fetus, or the long part of the fetus, to the long axis spine of the mother. So the spine may lay to the mother's right or to the mother's left. Longitudinal and vertical. Neither one of those things can happen. We have the fetal attitude, and that doesn't mean they have a nasty attitude. It just means the relation of the fetal body parts to one another. So generally, we want the head flexed to the chest. And of course, the knees are drawn up and the arms are tucked in. And so fetal attitude is very important because we have to have certain movements through the birth canal. We'll talk about those in just a minute, for the baby to actually turn and get through there, because you have not only the head, but you have the shoulders. So sometimes we can get a problem with that coming through the birth canal. So we have to be aware of that. The position we've already talked about, or presentation. So the position is denoted by the three-part letter abbreviation: right occiput anterior, left occiput anterior, right occiput transverse. That doesn't mean the baby's laying transverse. It just means the fontanelles and so forth, and the sutures in the skull are turned a different way. And we'll be talking about that in just a little bit more in a minute. The fetal station, we'll be talking about in just a minute, is the measure of the degree of descent of the presenting part of the fetus through the birth canal, and it's all relationship to the ischial spines of the mother's pelvis, and we'll talk about that. And then engagement means the head is down in the pelvis, and we call that zero station. And we'll talk about that here in just a minute. So here we go. During a vaginal exam, the nurse or the physician can palpate the fontanelles, the anterior and the posterior, and determine how the baby is turning. If it's head down, if it's turned to the right, if it's turned to the left, if the anterior fontanelle is anterior or posterior is showing up, either one of those, and we'll look at some pictures here in just a minute. The anterior fontanelle, we need to remember that it closes 18 months after birth, so it'll be open for a while. The posterior one, which is smaller, will close in about 6 to 8 weeks after birth. So you see here they have little suture lines, and they can overlap and shift around as needed to go through the birth canal. So here's just another picture of it. As you can see, the posterior, the anterior fontanelle is a real nice little diamond shape. The posterior is a little bit flatter on one side than the anterior. So this is, you can see the baby is laying on the long axis on letter A, the longitudinal lie, whereas the transverse is laying opposite, if you will, of the spine of the mother. And here's the attitude that we like to have. We want that head flexed. As you can see, if it's not flexed yet and it's not extended, look how out of alignment it is. And that's going to be very, very difficult for that baby to get through if that does not change. In fact, it might not make it through the birth canal. We just have to kind of wait and see. So here's some different presentations based on the presentation of the presenting part. And I'll show you some more pictures of this in a bit. But as you can see, on the far left, it says vertex presentation. The head is down, it's very flexed. And as you can see, the way the head is lying in the pelvis, you can see that it's going to have to rotate, and then the shoulders can get through. The other two, as you can see, it's going to be more difficult because things are not coming in the right order. We want the narrowest part to come first and then the wider, not the widest first. And so depending on the size of the baby, the mother's pelvis, all kinds of things come into play here. She may or may not be able to have a vaginal delivery. That is up to the physician, but as a nurse, and you go to do a vaginal examination, as you get more proficient, you'll be able to tell these things based on palpating not just the effacement and the dilation of the cervix, but also the anterior and posterior fontanelles. Okay, here's some more positions. As we said, the three-letter designation. The ROA is the right, occiput is anterior. That means it's on the right of our right, and it's toward the mama's front of her pelvis. The left is just the opposite. And then you see the ROT and the LOT, the ROP and the LOP. The posterior fontanelle is more prominent, and that is not good because that means the face is coming more of a face up presentation, and the widest part of the head is trying to come first. So that often the posterior positions, you'll hear a mother complain about a lot of back labor because it hurts her back really bad. And then there's some different types of breech presentations. We've got the frank breech, which means the whole buttocks is exposed. And the little feet, and you see the full breech again, so you can see how it does. And then you've got the footling. Okay, so we were talking a while ago about zero station, and you see the ischial spines of the mother's pelvis is how we determine what station the presenting part is in the pelvis. If it's up high, it's a minus station. If it's below, at the ischial spines or below, it's a plus station. And so plus station is what we need to have in order to have a baby. So when the baby is at zero station, we say that that head is engaged. It's in that pelvis. It's not going to go back up. It's going to keep coming down, hopefully. And then as you see on the picture on the left, as you get to +1, +2, +3 or 4, you're probably crowning and you're going to have a baby. So we get past those ischial spines, and that's what we need to do. Here's just another picture of it. If it's way up high, if it's above the ischial spines, we say that baby is not engaged. Even if she's having labor, she's not going to have that baby. That baby has to come down. And so there's a lot of factors that go into that, and we'll try to get into that with some discussion. There you go. Here's a little cartoon. As you can see, I'm at 0. From here, it's all positive. I'm on my way out. So just remember, zero station is at level with the mother's ischial spines, and you can feel those when you do a vaginal exam. So the mother's psyche, or her psychological preparation, is a very crucial part of what we're doing here. If she's terrified, if she's really tired, she's heard terrible stories about how horrible labor is, and they don't give you any medicine and all. And my mother had a long labor, and I'm going to have a long labor. My mom had big babies, I'm going to have big babies. None of that has anything to do with it, but a lot of people come with those preconceived ideas. And so then you got a lot of catecholamines going on because you're anxious and you're terrified, and then that kind of messes with your contractions. And we need to try to help them relax, dispel their fears, um, make sure that, we answer things that, we can have some control over. We can't take care of everything, but we try to reassure her and let her know that, we are going to be there. We're going to be helping her. It does have a huge impact on how the mother does during her labor.